of Spirituality in Sickle Cell Disease Care with Raina Cooper. We have our CME information, our accreditation and EOE statements. We don't have your disclosures from Dr. Ilonze. And for your CME credit, you can scan the QR code that's there on the screen, or you can click on the link in the chat box. The first screen will ask for your Blazer ID. If you don't have one, go to the next screen and that will ask for your information, more personal information for you. And then we also have just one announcement today, one last push for the NIH session that's coming up at the end of this week with Lydia Pecker. So we want to really encourage everyone to join. If you're interested and want to register, that link is in the chat box as well for you to participate in that activity.
Okay, so good afternoon, everyone. My name is Raina Cooper. I'm a nurse practitioner at Methodist Comprehensive Sickle Cell Center in Memphis, Tennessee, and I'm going to present a quick case about the role that spirituality plays with sickle cell disease. So this case is about a 24-year-old African-American female with sickle cell disease. She has SS genotype, and since childhood, the patient's had a very complicated disease course evidenced by multiple vaso-occlusive events, including recurrent acute chest syndrome. At a routine follow-up appointment back in February, the patient expressed the strong desire to discontinue all sickle cell disease drug modifiers by September and incorporate a holistic approach to manage the sickle cell disease course for herself. The patient has a strong belief in God and adamantly feels that she would be taken care of by the blood of Jesus. And furthermore, she also felt that regardless of being on any sickle cell disease drug modifiers, when it's her time to go, it would be her time to go. She was just at this point over being on any more medication. She just wanted to live her life. Next slide. So a little bit about her family history. Mother has sickle cell trait, has a very strained relationship with her mother. She experienced pretty severe beatings as a child from her mother for being, quote unquote, what she calls sassy, or either doing behavior that her mother considered disrespectful. And because of that, she left her mother's home and started to live with her grandmother at age 11. Her father, of course, sickle cell trait, has a strained relationship with her father as well, but he is available for her when needed. Her father did remarry. She does have a great relationship with her stepmother and feels that her stepmother is very attentive and a great mother-like figure for herself. She has a sister who's currently 17, is a mom to a 1-year-old son, and both the patient and her mom are huge supports for her sister and their nephew, grandson, respectively, for emotional and financial support. Her maternal grandmother, which is who she went to live with at age 11, recently passed away in November. Because of this loss, she has a lot of newfound depressions, substantial grief, and hopelessness. When she talks about her grandmother, she has a very, very close bond with her and often describes her as pure joy and just always smiling. This is who introduced her to her faith and her belief in God. Next slide. As far as her social history, she denies any use of tobacco or nicotine products. She occasionally consumes alcohol within a social settings, less than 4 drinks a week, doesn't use any illicit street drugs. She used to live with her mother and her sister to help with her nephew, but it was so many stressors for her. In order to reduce those psychosocial stressors, she moved back into the home that she shared with her grandmother, so she now lives alone. As far as her education, she did graduate from college from Mississippi State in May of 2021 with a major in communications. And she has aspirations of being an attorney, and now she has a little bit more time on her hands. So she's currently getting ready to study for the LSAT. Up until maybe about a month ago, she was employed full-time at Amazon, but she was terminated because of lack of productivity, which had a lot to do with some restrictions because of her sickle cell disease, not being able to do certain job tasks and also having to miss certain work days because of appointments. And so when she lost this employment, she did consider it as a blow to her, and it did kind of compound on some of the depression that she was feeling as well. But as she says, it was a blessing in disguise because she is working part-time as a manager at a thrift shop that her minister does own, and she has more time now to focus on things that she wants to do, like studying for the LSAT. As we mentioned before, she has a strong and profound faith in God, and she was recently ordained a minister on this past Sunday on May the 7th. She's currently single. She is identified as a she, her, hers. She's heterosexual, and she's not currently sexually active. As far as her review of systems neurologically, there's no history in childhood of any abnormal TCDs, no previous overt strokes, no history of any sickle cell disease retinopathy, with her last eye exam being in January of 2021. She does have an upcoming one in May the 17th, actually. Cardiovascular wise, she had an echo performed back in November of 2021. Some things to note is that her left ventricle was severely enlarged, but she does have normal systolic function. She has ejection fraction between 65 and 70%. Then her TR velocity is at 2.22 meters per second. It's to note that her left atrium is moderately dilated, and then her right atrium is mildly dilated. Back in February of last year, she had a cardiac MRI that revealed she does have left ventricular non-compaction. She is being followed and managed by cardiology here in the city, and she had a follow-up appointment on the 25th of April. Respiratory wise, she had a pulmonary function test performed back in 2018. There wasn't any obstructive or restrictive ventilatory defects. As we mentioned before, she does have multiple episodes of acute chest syndrome, but there's no history of pneumococcal sepsis for her. She does have episodes of dyspnea at rest and exertion. So we did follow with that. Did have a right-sided heart cath that was performed last spring of 2022, and it was negative for pulmonary hypertension. But because of the persistent dyspnea, she was referred to pulmonology, and she had that initial appointment on the 26th of April, and I'm still waiting on records from that appointment. GI-wise, negative for splenic sequestration. She does have a history of cholelithiasis, which is stable at the moment, constipation, which is stable at the moment as well. GU, she is negative for microalbuminuria. The most recent cystatin C was 0.9 milligrams per liter, and her GFR is at 78 milliliters per minute. She's up to date on her pap smear, does have a diagnosis of dysmenorrhea because she's not sexually active. She's practicing abstinence right now, but at the time that she did use condoms. But she has been referred to gynecology, has had counseling about progestin-based contraceptive methods, also those that would work well with treating dysmenorrhea. So she is aware of that. Musculoskeletal wise, she did have a DEXA scan performed that showed her Z-scores were within with expected range. She does have hypertrophy of bilateral breast and scoliosis that cause a lot of neck and back pain for her. So she has been referred to physical therapy for that, and as well to a breast surgeon to evaluate for a possible breast reduction. As far as hematology, as we mentioned, she does have the genotype SS. She was diagnosed in the newborn period. She was initiated on hydroxyurea back in March 1st of 2005. She's not been on any chronic exchanges or transfusions, just simple transfusions. The only toxicity she's had to hydroxyurea was just neutropenia, and her maximum tolerated dose at this point is 24 milligrams per kilogram per day. She did have an aplastic crisis back in 2007 where the parovirus titers were positive. Antibody screen for her is negative. Vitamin D deficiency she did have, but that has been resolved. Up to date on hepatitis and HIV screenings and immunizations. And as far as psychiatric, because of the loss that she's had, the trauma she's had in childhood, of course, there is some depression there as well as grief. So she's currently been followed by our clinic psychologist, and she has been very adherent to every appointment, with her next appointment being on May the 23rd. So recent ER visits and hospitalizations for this patient within the past 2 years. or what you can see back in November of 2020, she was admitted to the hospital that is pretty much on site for our clinic, where she had sepsis, acute chest, and sickle cell pain crises. She did an exchange during this hospitalization of 4 units of packed red cells, and she also had 1 unit of a simple transfusion during that hospitalization as well. Also, she was admitted back in May of 2021 at her sister hospital for a sickle cell pain crisis and a mild UTI, but she did not get any blood products during that hospitalization. And then the most recent hospitalization was back in November, around the time that her grandmother passed away, where she was admitted here on location for a sickle cell pain crisis and either pneumonia or early acute chest syndrome. She didn't get an exchange, but she did get 2 units of a simple transfusion during that hospitalization. And then back in April, she did go to the ER at our sister hospital for a sickle cell pain crisis. And as you can see below, that was the treatment plan that she did get while she was in the ER, and she was discharged home. As you can see, these are her current medications at this point: hydroxyurea, folic acid, Zofran, vitamin D supplementation, ibuprofen, Miralax, Lortab for pain, as well as capsaicin, and then albuterol to help with the shortness of breath. I wanted to include just a little bit of a screenshot of her hemoglobin, hematocrit, and MCV. You can tell that there are fluctuations with her hemoglobin levels, hematocrit levels, as well as MCV, but you can see there is varying compliance with her hydroxyurea therapy. She tends sometimes to be very compliant, but when psychosocial stressors really get the best of her, she will discontinue medication and stop with her therapy. And you can see the dips there, especially with the MCV and hemoglobin. But the most significant one you can see is around November of 2022. I just wanted to include some recent hemoglobin electrophoresis. I really wanted to kind of pinpoint back in 2021, November, October. You can see where she was really doing well with the fetal hemoglobin, slowly increasing from 12.5 to 13.7 to 14.5. And then, of course, it started to drop slowly, but surely, and to the point where we can tell she was getting off of her medications and all the way up until November, but you can't see there because we don't get them that often, but which led to her hospitalization. And the most recent one we have is back March the 15th, where she's right now at a hemoglobin of about 11.5, hemoglobin F. So to kind of wrap this up, she came back for a follow-up back a few weeks ago at the end of April. And she had mentioned that she was doing a 5K walking for Sickle Cell, I think it was Sickle Cell Foundation in Mississippi. And during that time, she just kind of had a revelation where she was like, if I'm supporting sickle cell and I'm really, working on my faith and I'm becoming an ordained minister, I have to make the decision to live and not die, because I'm choosing right now to die if I don't take my medicine. So she really made that decision. And because of that, at that point, she has reinitiated her hydroxyurea. We've discussed Indari as a means to kind of meet her in the middle at that point where she decided that she wanted to go the holistic route. She was okay with initiating that at the visit. Her follow-up appointments, she would schedule them and miss them, schedule them, miss them. It was like pulling teeth to get her to follow up with them. And she already had proactively rescheduled those appointments and had presented to some of them. And then also she's maintained all of her appointments with our clinical psychologist since she was referred back in February, and has been very compliant with following up with him and doing the things that she needs to do to manage her depression and her grief. So the last slide. So we know the role that spirituality and religion plays with our sickle cell patients in managing pain and managing how they cope with pain. But this was a little bit different because, how do we deal with the role spirituality plays when it comes to adherence to your treatment plan? So we all know the risks that are associated when we don't follow through, when our patients do not follow through with their sickle cell disease drug modifiers. But it's important where we have this environment with our patients where they feel comfortable to discuss alternative therapies like my patient did with me. So I kind of wanted to discuss if you have experienced a situation with the patient like this, and if so, what was the plan of care that you had for them? And secondly, for me personally, religion is huge. My faith is huge in my life, as it is in many of our patients. And in the event that our patients' beliefs lead them down a path that is not going to yield a good patient outcome, how do we as providers support them on that journey?
Thank you, Dr. Cooper, for an excellent presentation. Does anyone have any comments or any possible answers to her questions? I guess for me, the question that I would ask is, do you know what made her change her mind to decide to live and not die?
I think that for her is that when she really had a moment to think about that, she was really grieving the loss of her grandmother. And I think a lot of her decisions, as we were talking about in that visit, was more clouded with grief and loss. And at that point, she really just did not want to live. She just kind of really wanted to die, because her grandmother, the most significant figure she had been gone. So I think with her, really getting more profound in her faith, becoming a minister and really choosing to support, sickle cell and its causes, like how can I tell people to take their medicine and do all these things that I'm not doing. I have to be a better example.
Yeah, as a pediatric hematologist, for me, most times that our patients come to clinic, they come with a caregiver, either a parent or a legal guardian. So, when I encounter these kind of situations, I typically lean on the parent or the caregiver to, make them comply and take their medications. Mm-hmm. So I'm not really sure how that would work in the adult setting. So I don't know if any of our adult colleagues has any comment on that.
Hi, Dr. Morma here from University of Mississippi Medical Center. Just wanted to ask our erudite speaker, when you use the word holistic, I was a little confused. When you say holistic, do you mean, because the way the lay person says holistic may be different from what we as medical people call holistic. So what did the patient really mean when she said she wanted to start holistic care? Because in my world, when they say holistic care, that means they're going to look for health stores, health foods off the shelves. That's kind of what it interprets to me in my setting. Mm-hmm. It could be different elsewhere. Yeah.
That's what it was. It's more of looking for supplements, to take. She, of course, people consider doing their research, whatever they may hear on social media, different nutritional supplements that may work for sickle cell disease, trying to incorporate meditation, for pain, different types of rubbing oils, massage therapy, things like that. But that's what her plan was at that point in time, to not be on anything that is what she would consider man-made medication outside of, supplements.
Okay, so she changed her mind from holistic to taking the hydroxyurea?
Mm-hmm. Yes.
Okay.
And considering that her disease course is very complicated and it has been, I support her in that decision. I also, did add the Endari just and chance she did change her mind. That's something that, that we can kind of work in the middle to still keep her managed with her sickle cell disease. And I also have other things, like as well as finding other ways to manage pain for her if she does decide, and I hope that she doesn't, to go back to what, to try something that is outside of her sickle cell modifiers.
Yeah, most of us will get a chaplain if it was in the hospital. Mm-hmm. Obviously, in the outpatient setting, it's more difficult to get a chaplaincy consult. Some people call it conflict of interest. That means you are the provider, and then we all encourage spiritual counseling. I do spiritual counseling. What some people say is, when you make a promise medically, will it be the same as making a promise spiritually? For example, the patient says, am I going to live? Now, as a Christian, you can say, I'm going to believe with you to live the question now is, as a physician, when you say that, can the patient take you out of context? So that's why people always encourage getting another person who is not maybe bound by his or her ethics, you know. So that's why we always encourage getting a chaplain to counterpart you when you speak on such, you know, not necessarily medical issues, but they're still medical, but they're not as medical.
Okay.
I don't know if that makes any sense.
Yeah.
Yeah.
Could this patient be depressed? Was she receiving any psych help, you know?
She was severely depressed. We did initiate her on duloxetine, but she did take it for probably a week or two and decided not to take it. But I'm still watching her closely for that, myself as well as Dr. Potts, our clinical psychologist, and she is being managed there. And we also have access if she needs to get to psychiatric, psychiatrist, we can get her referred over for that if need be.
It seems like she's experiencing some deep-seated loneliness in her, and she's resorting to spiritual solace to get her out of this despair and misery. So it's very hard, you know. I mean, I obviously, so many of you are probably more advanced than me in spiritual knowledge, but I always think that, you know, it's also like a manual of life. It's very hard to just teach a person just in a counseling session or something. There's so much more to it than we just make it as a casual thing that we do spiritual counseling and other things. But I may be wrong, but it's a lot more to it than meets the eye.
Right, I agree.
Any more comments?
Yeah, hi, this is Tarun Aurora. Rana, you know me. We work together at Methodist.
Yeah.
I'm a St. Jude and at UT. And I will say Rana's a phenomenal MP with our patients. And I actually look up to you a lot, and I've learned so much from you. And one thing that I've learned through this presentation is I really appreciate with this patient how, you know, it seems like she's doing a little bit better. She now has this, you know, will to live, will to thrive. And I think a lot of it has to do with her kind of newfound purpose. And it's a cell disease that, you know, many see as, you know, it could bring them down so easily, recurrent hospitalizations, a lot of chronic pain issues. And instead she's using it as a tool to help others. And so to me, just based on your presentation, she's really found a higher purpose, and she's using this chronic disease as a way to encourage others to do as well as she's doing. And I feel like that's, my guess is that it's probably playing into her having a better mood, more energy, things like that. So I really appreciate you sharing that with us. And I think it's helping her.
Thank you. It was like night and day from seeing her in February to April. It was like a whole new person, like completely a 360, like there was joy, you know, it wasn't like a solemn, you know, flat affect. It was very, it literally, like I left the room and I was in tears because I was so worried about this patient. And, you know, I'm going to, you know, keep working with her closely and, you know, try to continue to see if we can stay on this plan with her.
Okay, thank you.
Thank you.
Okay, any more questions, comments? I think we can move on to our didactic session.
Okay, so our didactic is presented by Dr. Ilonze here today. Dr. Ilonze is a graduate of the University of Nigeria College of Medicine, where he finished medical school. He attained his master's degree in environmental health sciences from the State University of New York in Albany, New York. He completed his pediatrics residency at Woodhull Medical Center in Brooklyn, New York, in affiliation with NYU. He subspecialized in pediatric hematology oncology at the University of Oklahoma and Oklahoma Health Sciences, and joined the UAB faculty in 2021 with a focus in classical hematology and cardiovascular complications in children with sickle cell disease.
So I just wanted to review vaccinations in children with sickle cell disease. I don't know if you're like me. By that, I mean other pediatric hematologists who sort of struggle to remember the vaccination schedules and how to do the catch-up immunizations. And, I was also going to review the reason why we do vaccinations in children with sickle cell disease and the reason why we started prophylaxis in them with penicillin. Next slide. So I thought I would start by reviewing the spleen. I think this takes us back to medical school. So advance. You can advance the slide. Yeah. So the spleen is basically the site of filtration and innate immunity. And what it does is that it does opsonization of encapsulated organisms, and it's also the site of consumption by macrophages. And also is the site of the primary and secondary adaptive immune responses. And by this, the T cells get primed by the APCs, they interact with B cells, and also the T cells class switch as well. Next slide. So if you again remember from medical school, you have the red pulp and the white pulp. The red pulp really is where the mechanical filters of the function of the spleen take place. And from there, the rigid particles greater than 1 micron in size is removed. Old red blood cells are removed as well. And also unopsonized bacteria are also removed. And the white pulp, if you can see, sort of like those white rings around there, is collection of lymphocytes and macrophages, and it's also immunoglobulin producing B lymphocytes. And these produce the antibodies that target polysaccharide antigens on surface of encapsulated bacteria. Next slide. So I wanted to point out the marginal zone. It's a site of specialized B cell population. And this zone produce B cells that respond to polysaccharide antigens that are generated around 2 years of age. And they trap the particulate antigens and present them to lymphocytes as well. And also, another function of the spleen in general is that it leads to rapid destruction of sickled red blood cells. And it's this congestion of the spleen by the sickled red blood cells that leads to fibrosis and functional asplenia. Next slide. So functional asplenia is basically defined as either partial or complete loss of function of the spleen, and it's most frequently from sickle cell disease. And as I mentioned earlier, it results from repeated vaso-occlusion in the spleen. And functional asplenia occurs in 94% of children with sickle cell anemia by 5 years of age. And this predisposes to infection, especially infection by encapsulated organisms. Next slide. So the functional asplenia makes patients with sickle cell disease more susceptible to infections. And the encapsulated organisms are strep pneumo, H. influenza type B, Salmonella, and Klebsiella. And actually, before the advent of vaccines and penicillin, the incidence of invasive pneumococcal disease was around 6 episodes per 100 patient years, and that was 30 to 600 times more than that of children without sickle cell disease. And it also had a high mortality rate. And there was a peak at around 3 years of life before attempts at prophylaxis. And the pneumococcal vaccine became available in around 1970s and early 1980s. Next slide. So I wanted to start by reviewing the landmark trials. I'm sure some of my pediatric hematologists here or other hematologists here know about these clinical trials. But the first landmark trial was the PROPS trial, and it was carried out in 1983 to 1985. It enrolled children 3 to 36 months of age, and it basically divided them into 2 cohorts. The first cohort was the PenVK group, which had around 105 patients, and these patients were randomized to receive penicillin 125 milligrams twice a day. The other group got placebo, and they got vitamin C 50 milligrams twice a day. So there were 15 episodes of pneumococcal septicemia. There were 13 in the placebo group, and out of these 13, 4 developed fulminant disease, and there were 3 deaths. And there were only 2 episodes in the penicillin group, and there were no deaths. So there was in total, 84% reduction in risk of invasive pneumococcal disease in children on daily penicillin compared to placebo. And because of this, the trial was terminated 8 months early, and the recommendation was made that children with sickle cell disease be placed on penicillin twice daily. Next slide. This is just a graph from the study showing you can see the clear difference between the patients on placebo and patients on penicillin. Next slide. So again, on infection, older children have lower incidence of pneumococcal infection compared to children less than 5 years of age. And this is believed to be as a result of increased ability to produce an immunologic response to encapsulated organisms. However, there was also a concern that taking penicillin all the time may lead to higher rates of penicillin-resistant organisms in older children. Next slide. So this led to the PROPS-2 study, and it examined if penicillin prophylaxis could be continued at 5 years of age. So the patients received prophylactic penicillin for at least 2 years before their 5th birthday, and received PPSV 23 vaccine between ages 2 and 5 years of age. So these patients were continued on penicillin 250 milligrams BID, or some of them continued on placebo. So this study enrolled 400 patients, and in total, there were 6 patients that had non-fatal systemic strep pneumo infection. The PENVK group had a rate of 0.33 per 100 person years, and the placebo group had 0.67 per 100 person years. So the study concluded that children with sickle cell anemia, that's SS and S beta thal 0, without severe pneumococcal infection or surgical splenectomy, and receiving comprehensive care may safely stop prophylaxis at 5 years of age. So that's been our practice here at Children's of Alabama. We typically stop penicillin prophylaxis at 5 years of age. Next slide. So on to vaccines. And for me, while I was preparing this lecture, I took a dive in infectious disease as well. And, the findings, personally, it helped to improve my knowledge. So on the right, you can see PPSV, and then you can see the polysaccharides, the sugar molecules. And then you can see PCV, you can see the polysaccharide and the sugar molecules, and you can sort of see that blue carrier protein there. And you can advance. So a carrier protein is used to elicit T-cell dependent activation of B cells. So from my study, I'm not an infectious disease expert, but what I read is that children less than 2 years of age, they have poor response to these antigens like 2 polysaccharide vaccines due to immature marginal zone. So if you recall the marginal zone that I mentioned earlier, apparently because it's immature in children, they are not able to respond appropriately to just the polysaccharide vaccines alone. Next slide. So therefore, they came up with the pneumococcal conjugate vaccine, and they found that if you link these polysaccharides to a carrier protein, in this case CRM, which is like a diphtheria toxoid protein, it triggers a T-cell dependent antibody response, which is able to produce a response to these vaccines. And next slide. So I dug into immunology as well. And on the left, you can see T-cell dependent activation of B cells. So if you remember your immunology, the main difference is that for the T-cell dependent activation of B cells, you can see on the right, they need a helper T-cell to help them generate an immune response. So that is sort of what the carrier protein does to these conjugate vaccines. Compared to the T-cell independent response, where the T lymphocyte either differentiates into a killer cell, cytotoxic killer cell, or it releases cytokines that help to recruit other T cells, and they get activated and they attack and kill the antigen, or they differentiate and form memory B cells, and some also produce specific antibodies. Next slide. So then on to the pneumococcal vaccine. So it was first licensed in 2010. And because the splenic marginal zone compartment is still immature in early life and it was not very responsive, so they now found that coupling or conjugation of the polysaccharide to a carrier protein greatly improved the immunogenicity. And as I mentioned earlier, it changes the nature of the anti-polysaccharide response from T-cell independent to a T-cell dependent response. And prior to this, I think they were only able to do the PPSV23, which is only given at 2 years of age and older, because then the marginal zone is developed and they're able to produce a response. However, with the production of these conjugate vaccines, they're able to give these vaccines to those less than 2 years of, or even younger. So the PCV13, and it's so named because it covers the most common 13 serotypes that are responsible for causing pneumococcal infection. We typically give these at around 2, 4, 6 months of age, and then a 4th dose at 12 to 15 months of age. And then for children that are behind on their vaccines, 2 doses of PCV13 for children 2 to 5 years of age who have not received the PCV13. Next slide. And then, as I mentioned, the PPSV23, we typically give it at 2 years of age or greater, and it's administered greater or equal to 8 weeks after the last indicated dose of PCV13. And it typically requires revaccination 3 to 5 years after the first dose. And this depends on if it's the ACP or another advisory board. It all varies by advisory board. So because of the fact that the spleen is a little bit mature by 2 years of age and able to respond, and the PPSV23 is given by 2 years of age, we typically defer elective splenectomy till 2 years of age. For example, patients that have splenic sequestration, the recommendation is that after the first splenic sequestration, you're likely to have more, and it's recommended that you do a splenectomy. So in that case, if the patient is less than 2 years of age, sometimes, most times we bridge them with either transfusions until they're up to 2, so we can do the 23 vaccine, and then we can plan for an splenectomy after the vaccine is given. Next slide. So these are vaccine schedules from up to date, just showing when to give these vaccines, because I know in clinic I struggle, like, you know, they come in, they don't have any vaccine, or maybe they've gotten 1 or 2 13s and they've not gotten the others. And I will say that in our clinic, the vaccines that we typically give is the PPSV23, because the pediatricians typically do the Menveo and the PCV13 as part of the scheduled vaccinations for these children. Next slide. And also, as I mentioned, you can see here, it all depends, have they had any dose of the 23? And if they have they had 1 dose of the 13 or the 4 of 2 doses or 3 doses? So this sort of just gives you the schedule. I don't think anybody has to memorize this, can just pull it up and look it up. But it's recommended practice to always review the vaccination record of any patient with sickle cell disease, especially children, when we see them for their comprehensive visits in clinic. Next slide. So the meningococcal vaccine, again, primary series, 2 through 6 months of age. And again, interesting for me, the Menveo is meningococcal vaccine against the serotypes ACWY. And because it's CRM, which is the same carrier protein used for the pneumococcal vaccine, you're able to give it at a younger age. However, when the patients are older, and if you look down here, you can see Menactra. So Menactra is only recommended for children aged 2 years of age and above. And I think it's because they don't have the carrier protein CRM that's able to elicit an immune response. So Menactra is only recommended for children aged 2 years of age or greater. And of course, there's a schedule for catch-up vaccines for age 7 through 23 months. Next slide. So the meningococcal vaccine, there are 4 licensed in the US, 2 conjugate vaccines for the serogroups ACY and W135, and 2 serogroup B meningococcal vaccines, MenB. Next slide. So again, this is just a catch-up vaccine for patients that have not been vaccinated. Just a catch-up, just an easy reference in case anybody needs this in clinic. Next slide. For the MenB, it's primarily recommended for those that are greater or equal to 10 years of age. And there are two types. There is the Bexsero. Bexsero is 2 doses, and it's given greater or equal to 4 weeks apart. That's the one that I typically give. And then there's the TrueMember. TrueMember is 3 doses. So the reason we typically do the Bexsero is because it's 2 shots, and they can get the shots in 2 visits, as opposed to the TrueMember that is requires 3 shots. Next slide. So you can see this is a graph from a study published by Payne et al. On the left, and if you Sanjay can advance, there are some arrows that will pop up here. So on the left, you can see before the initiation of prophylactic penicillin and vaccines, 1979 to 1989, those were deaths per 100,000 population, and the highlighted bars are children less than 5 years of age. And then 2015 to 2017, with the advent of prophylactic penicillin and vaccines, you can see that the deaths have dramatically reduced. Next slide. So penicillin prophylaxis. So it's recommended to administer to all children with sickle cell disease until the age of 5. Up to 3 years of age, it's 125 milligrams twice daily. And at 3 years, you increase to 250 milligrams twice daily. And if there is any allergy to penicillin, we typically switch to erythromycin twice daily. I don't know about other institutions, but right now there seems to be a penicillin shortage. So we are prescribing amoxicillin to patients that are not able to get penicillin in clinic. Another curious thing we've experienced in clinic, some parents just elect to continue past the age of 5 because they say they feel more comfortable, especially after COVID. They're worried about infections. And in such situations, I personally explain to them that, it's fine if they want to continue. It's a personal decision, but it's also fine if they don't want to continue. And I think some centers continue penicillin past the age of 5. But I'm not sure which centers, but I think some centers do that. And then if there is a history of infection with encapsulated organism, our practice is also to do lifelong penicillin prophylaxis. Next bullet point. And also if there's surgical splenectomy, also we recommend indefinite penicillin prophylaxis. Again, when some of our patients go over to the adult side, I know sometimes they stop the penicillin prophylaxis in surgical splenectomy patients. And I think also the British and some other countries do maybe a couple of years after surgical splenectomy, and then they discontinue. They do not require indefinite penicillin prophylaxis. Next bullet point. And then we also we always recommend to all our sickle cell patients that fever is a medical emergency and they need to be seen and evaluated for any fever. And then, of course, one of the biggest issues with penicillin prophylaxis is compliance. If you have a medication that you have to give every day, it's very difficult. But we always emphasize that it's important for them to get their penicillin twice a day. Next slide. And what we do for fever in children is many times we always educate them in clinic that any fever, they need to call and let us know. And then we will ask them to go to the ED. In the ED, they will collect blood cultures and do a dose of IV Rocephin. And then if there is a history of surgical splenectomy, these patients we typically admit for a 48-hour rule out. And this can vary by institution as well. And I think that's all I have. I don't know if anybody has any questions or comments. I'm sure some institutions do things differently. So willing to listen. Any questions, comments?
Yeah, hi, thanks for the presentation. What's your adherence rates for these vaccines? Have you done your own internal QI project, and what percentage of patients receive the prescribed vaccinations?
So I have not done an internal QI project and I do not know. So we rely or we believe that the general pediatricians in the community give the meningococcal and the pneumococcal vaccines. And then here in clinic, we typically focus only on the pneumococcal 23 and the Bexsero, that's the MenB vaccines. And then, so the issues we've had sometimes is that when we attempt to give some of the other vaccines like the pneumococcal, because of a delay in showing up in the registry, sometimes the pediatrician repeats those vaccines as well. And then there is now, the patients end up getting two vaccines, or 2 doses of the same vaccine, and sometimes they get really upset. So to not run into that problem, we typically let the community physicians give the primary vaccines. And then for our internal rates, honestly, I don't know. We've not done a QI project because we see sickle cell patients here in Birmingham, and then we have off-site clinics in Tuscaloosa and Montgomery. So that would be a good QI project for us to do and see what our compliance rate is.
We had done such a study some years ago and published it, and we were surprised that the rates were quite low, including for complete HIB series, for example. But we have turned it around dramatically. We have added clinical pharmacists to our clinic, and in my sickle cell clinic, before I start my clinic, I have a list of all the vaccines every single child needs. And we have a vaccine clinic 1 floor below. So all the vaccines the patient needs are automatically given before the child leaves. And it's most of the practices which are on Epic can also see that it's on Epic. So it's a big shout out to have somebody like us, clinical pharmacist, which they can really change things for you in the clinic and enhance the quality of care, because it is extremely important to have high rates of vaccination in this population.
Would you mind putting your publication in the chat, please?
Let me find it. Sorry, I'm sort of not in front of my computer.
Okay, or maybe some other time,
or maybe
some other time this week, you could send it to UAB.
I will do that. I'll send it to Sonia. Is that okay?
Yes.
Yes, that's fine.
Yeah, thank you.
I had a question. Thanks, Dr. Ilonze. This is Vishwas Sakalkar from Augusta University. Thank you very much for that wonderful talk. Actually, I just want to give you one quick update. In our institution also, we had a lot of difficulty having patients getting all the vaccines, but we got a new nurse a year ago, and she made a point to put the status of every patient, and at every clinic visit we used to give them, and now we do need to make write it up to how much difference it made by making that rule. One question I had for you quickly, the PPV 23, you had mentioned, and we used to do before too, at 2 years and 5 years. But I heard a lot from the insurances. Our pharmacy said recently that the insurance would not give or authorize or pay for giving it before the age of 7 years. That means 5 years after the first dose. So after 2 years, the insurance would not pay if you had given it 2 years up till the age of 5 years, or 7 years, sorry. So we cannot give it at 5 years. What is your experiences in that? Or if anybody else has some other experience, because it did hurt me, but we didn't have a choice.
Yeah, I've not had any experience with insurance denying the vaccine for PPSV 23. So I can't speak to that. I don't know if anybody has any experience with that.
So basically the insurance would not authorize giving the second, bolus until it is 5 years from the first bolus. That's what
I think, because so when I was researching the 23, there were 2 different guidelines, and if you look at it, it says that the second dose should be given. There's a range 3 to 5 years. So it depends. I don't know what. I have to look and see if the CDC outlines specifically if it's 3 or 5. Maybe that's what they are basing it on. But I know there is a range to which you can give the 23. So I think that may be what the insurance is referring to.
Good, thanks a lot.
Yes, sir.
Yeah, in our state, we have a much more laxity as far as state insurance patients are concerned, because we did pass a law last year called the Emily's Law, named after one of our patients, where any decision made by the provider when it comes to a sickle cell patient, whether it is vaccine or treatment or imaging study or any other modality, cannot be denied. And we are supposed to notify the state if any such denials happen. So that way our patients are well protected from, those type of things.
Oh, okay, that's good to know.
Hi, Dr. Ilonze. That was a great presentation. So this is Stephen Obaro, in case you're wondering who is speaking. You gave an excellent overview of the technical details of the immunologic mechanisms. I want to just raise a couple of comments for caution. Now, in general, even though these vaccines have been optimized for immunogenicity with the conjugation to a protein moiety, children who have sickle cell disease tend to mount a suboptimal functional response compared to those who don't have sickle cell disease. Now, the other observation is the fact that they tend to be more at risk from pneumococcal infections caused by pneumococcal serotypes that are not included in the vaccine.
Okay.
So I would want to urge that for all the centers, I don't know if people are following very closely to actually document what's the commonest cause of bacterial infections in children with sickle cell disease who have been fully immunized and who are optimally taking their penicillin prophylaxis. We need to remember that these children remain at risk from non-typhoidal salmonella infections, for which we currently don't have any vaccines. And I also have a small question to raise with you, that what advice do you give these patients when they go on international trips, particularly those who return to Africa?
That is a good question. Well, we try to make sure that they are optimally vaccinated, that they received all the vaccines. And if, because I think the shelf life of reconstituted penicillin is only 2 weeks, 14 days. So sometimes we switch them to something like amoxicillin or something. But I don't think we typically have, I've not had a lot of patients that go back to Africa or Nigeria, but the few I've had, that's typically what we try to do before they travel. Yeah, but I think you make excellent points about the other encapsulated organisms and the suboptimal response to vaccines in children with sickle cell disease.
Yeah, so I would add that as an infectious disease physician, I would urge malaria chemoprophylaxis for kids who are going back to Africa. That needs to be taken very seriously, in addition to their penicillin, and yes, hoping that they're also fully vaccinated.
Thank you.
Thanks very much. But I think there is going to be a lot of room for looking very closely at what the current trend is across all the centers, particularly centers that manage a large number of children with sickle cell disease. What exactly are the current trends with the etiology of serious bacterial infections in these children?
Thank you.
In 23 years I've been in Louisville, I've lost only one child to infection. And we've had just a few patients with pneumococcal infection, maybe less, I can count in my hand, less than 5 maybe. And salmonella, again, not many, but all the points the infectious disease doctor made are very strong and very important. But clearly, vaccinations have had a huge impact on the patient. And overall, other herd immunity because of, other patients also getting pneumococcal vaccines has also contributed. I remember in the early stages of my residency, I would see a lot of patients with meningitis, H flu and pneumococcal meningitis in sickle cell patients. That we lost a lot of patients to those complications. But we have come a long way, and vaccines are important. That's why we strive to make sure that everybody is a high rate of immunization is maintained.
Okay. Thank you very much. Any other questions, comments? Okay, it's 4:57. Thank you very much and have a great day. Thank you.